Well, thank you so much for the warm introduction, and I'm looking forward to getting back to Australia. I wish you could be there now with the way things are in the U.S., but I guess I'm taking a somewhat view from the U.S. as well as a little bit of our experience in Australia in our presentation today. I'm very proud to have the time to spend with you and the exciting meetings that ANDHealth puts on. So today I'll talk a little bit about our company. That'll give you perspective about the how we operate as a large healthcare IT company, but work with small digital health companies. Some trends in the US, some of COVID impacts. One of the spotlights really will be on both telehealth, but also what we call whole person care in the US. And that's just making sure we're dealing with the social determinants of health, behavioral health, and physical health. Some predictions about what I think is going to happen to digital health in the future, and of course we'll open for questions. So a little bit about our company. We like to say that we're an entrepreneurial 45-year-old company, but we are 45 years old. We are traded on the NASDAQ, and we serve over 350 US health plans. So in Australia, of course, it's, and some people call it insurers. In the US, we call it health plans, and you call them health funds. We serve over 50 federal and state government agencies, so we know how to deal with government. Have been doing that since really the time the company started. And we have about 30 offices in the US with very few people in them right now, though we have about 3,200 employees. They're all work from home. And we have an international product development site in Hyderabad. I think you heard one of the earlier speakers talk about measurable results, and that companies in the US, and particularly the health funds or health plans in the US, need to see that. We save or recover about $5.5 billion a year for our clients. So it's a very sticky set of solutions that we have, but we also manage significant amounts of data. And I wanted to at least walk through the kinds of data that we have. So in the US, of course, all the data about yourself is stored in one repository at your health insurer. Whether your health insurer is a government plan or a non-government plan, typically offered through your employer. So we have all that eligibility information. We know who's covered by whom. And then of course we get claims from our clients and about 1,300 different trading partners we work with. And we process over 3 billion claims running through our system each year, heavily focused on data analytics. That really is our IP, is our custom-built analytics and predictive modeling engines. Now, our solutions are a little different. Some apply to the Australian market, some don't. Coordination of benefits applies in Australia if you had a car accident, but the health insurance claim really should have been paid by someone else, or it was paid by your health fund and it should have been paid by the auto casualty insurer. But in the US, it's a much bigger coordination of benefits function, determining which insurance that you may have as primary. And for our program called Medicaid, which is for the low-income people, if you have other coverage, that has to pay first. So that's a big product line for us. Payment integrity, which there are solutions in Australia. In fact, we partner with a company based in Sydney called Lorica Health that does similar types of edits and analytics on payments made by health funds to help route out fraud, waste, and abuse. And then probably what's really been our newest line of business is population health management. And we'll talk a little bit more about our approach to that. And then of course, we work with all of our clients in terms of our, I think I might have, oh, there we go. All of our clients in terms of how can they use our tech services better. You heard today that data is the answer. You just heard from Drew that the interoperability of data is so important. So what we do in our company is look at all of this data that's coming from disparate sources, government, health plans, employers, could be trade unions, and we match them to find what we call a single belly button, right? So everything about Bill Lucia, his health insurance coverage, the claims that he's had, which equals the medical services I've had, and all claim types, anything from vision to anything medical, dental, behavioral health, physical health, um, and any kind of health service that I've received. We also bring into that consumer self-reported data. We do a lot of interactive voice response, text, or email conversations with clients. Today, we're moving that, of course, to an AI chatbot. But they give us a lot of information about themselves that helps us figure out that they have a social determinant of health that has to be solved, meaning they could have food insecurity. So that's a little bit about the data and how we use huge data. I want to talk a little bit about our footprint in Australia and why actually I'm speaking here, but we spent about 5 years in Australia. Um, we don't have a dollar of revenue yet, but that doesn't mean we won't within the next year. But we really saw Australia as a market that was hungry for both digital health and for new solutions, and open to working with US companies. So the first thing we did was we joined the Digital Health Cooperative Research Corporation. Many of you probably know about the DHCRC. We joined them from the beginning. We are the largest industry partner. And we really did it because we wanted to have access to academia to do appropriate research to help us continue to refine our analytics. And so today we have 4 projects that we're working on, and I'll highlight one that we're doing with the University of Sydney at West Mead Hospital in Sydney. But we're doing an awful lot about opioid addiction and treatment, and we're also going to kick one off with Stanford University on predicting COVID-19 infection rates, determining what types of people have more problems, social distancing, et cetera, particularly in our lower income population. And of course, University of Canberra is using very interesting technology to identify social determinants of health just using geospatial technology. So we'll talk a little bit more about that. What we bring to the table also to Digital Health CRC, and if you're a participant or you're interested in becoming one, we have loaded 19 million lives in a healthcare database of about 850 million claims. So these are 19 million people over the last 5 years and all of their claim data. As I said before, any service they've received, whether it's dental, vision, anything medical, pharmacy, behavioral health, you name it. And that is de-identified. Our clients allow us to do that. And that's offered to the Digital Health CRC for researchers to actually do research on. So we really bought into this industry-driven, academically powered health research, and we're now taking the results of that and loading it into our predictive models that our health plans or integrated delivery networks might use. We did recently make a strategic investment in Med Advisor. Some of you may know the company. They are based in Melbourne. And they are probably one of the first and a very large medication adherence company that's working with pharmacies, but to send transactions to patients to remind them to take their medication. As you might guess, that's one of the biggest issues we have in the healthcare system is people who either don't regularly take their medication or they stop taking their medication because they're feeling better, but they need to continue to. So, and then this year, through direct sales, we'll be hopefully having a commercial market entry into the Australian market. Some may say, well, why the Australian market? Because the US market is so huge. Again, it's because we think we can bring a lot to the table, and because the government, through the CRC, has created $50 million to invest in digital health and building the digital health economy in Australia, which I think is amazing. Let me talk a little bit about this West Mead pilot. We have a product line called ELISA, and what it is, So you heard Drew just talk about a remote device communicating with the patient, but there's a large swath of patients that are not going to use a remote device, or they really need that more direct communication for them to be compliant in their regimen of managing their disease state. So we have a system that does all of that messaging to the patient using behavioral science, so behavioral change theory, to get you to take action. And then that system, of course, will reach you via interactive voice response, email, secure digital, text, or even a live agent. But I'll talk to you a little bit about the project we have going on at Westmead. Westmead Hospital, which is a huge hospital in Western Sydney, has a rapid access cardiac clinic. In fact, they have some rapid access clinics for different diseases. And that's to keep people really out of the ED, and also not necessarily going into hospital, but staying within the clinic. And so what we're building for them is once somebody goes into the rapid access clinic and we know that they have atrial fibrillation, that what we do within 24 or 48 hours from that visit is we have a patient-reported assessment that is developed through this engagement with the patient. We confirm the medications they're taking. We support them getting in touch with their GP. And of course, we link them to educational content based on what their concerns are. And then in about 4 or 5 days after them arriving at that clinic, we'll make sure they had a GP appointment. Again, all of this is done electronically. We'll make sure they're adhering to the medications prescribed at the clinic. And then we'll start to talk to them about, again, digitally, barriers to care. So how do we connect those resources? If you don't have transportation, can we connect you to a Lyft Health car? All of the types of things that are keeping people from seeing a doctor. And then 30 days, or depending on the individual state, we will continue to assess the patient. Again, all of this electronically, and then we'll continue to educate them on any complications they have. And then there's continued routine check-ins. What we're going to do in the pilot is, after 6 months, everyone who's been in this direct digital engagement will be in a focus group. And then what we'll continue to do is run this. And our hope, and Westmead's hope, is we'll run this for their rapid access cardiac clinic, and we'll move it on to their other rapid access clinics that they have in the hospital. In the US, this type of engagement is typically done from the health plan or the health fund, because it's one of their jobs is to try to keep you healthy. So they want to make sure you're doing all the things you can for your disease state. Not all do it, and not all do it the same way. But that's a little bit about our footprint in Australia, which I'm hoping will be expanding shortly. Let's talk about the US healthcare industry trends. And you've heard these, and you've heard speakers today talk about it. But medical cost in the US continues to rise dramatically. We're over 3.5, probably close to $4 trillion to spend. It's believed that about $1 trillion of that is wasteful spend, so overutilization, spend because of underutilization, fraud, waste, and abuse, and people not being able, people actually getting into a further disease state because they're not managed well, and we spend more money. So there's a lot of waste in the US healthcare system. We do cost containment as one of our product lines, so it's a very lucrative and attractive field. We are moving to value-based care. Now, that's a very different payment model. And I know the word managed care is not one that goes over real well in Australia, but we're moving more to value-based care where the physicians and those providers that are managing a group of patients are responsible for the payment, and they get a fixed payment from a health insurer or the government to manage that patient. A fixed per month payment. They don't get the bill every visit. And then they're responsible for taking care of that patient from soup to nuts and all of the services and paying for those services. So they're very motivated to get high outcomes so that they're paid on value. And we are trending towards that. It's not moving quickly, but we are moving in that direction. Of course, in the US, and particularly with COVID, but government-sponsored programs, and we have a number of them. Your Medicare program, we don't have anything like it. Our Medicare program is for the aged, blind, and disabled population. Our Medicaid program is state and federally run, and it's for lower income population. And then there's employer-sponsored insurance. There's also Veterans Administration or Veterans Affairs like you have in Australia. But the growth of the government programs is outpacing what we're spending on the commercial side in terms of the pace of spend. And that's because the US, we're getting older and we're living longer with multiple comorbidities. We're not the healthiest nation. And so all of that is on the backs of government spend at this time, whether it's a payment directly from the government or to a health plan to manage your care. And then, as I talked about before, there's a huge focus on the whole person. Nobody really does this well, but it's very important because you're never going to get somebody to be adherent on their medication if A, they can't afford it, or they're choosing between food and medication, they feel unsafe at home, they have no transportation. You have to solve those social determinants in order to solve the behavioral and medical, and we feel very strongly about that. And that's integrated into our predictive and prescriptive models. And then you just heard Drew talk about tech-enabled clinical care delivery. It continues to go forward in the US, connecting via the Internet of Things. And as Drew said, relatively easy connections with the remote devices and monitoring facilities and or GPs or specialists. It is moving, it's becoming more popular, but it's not necessarily hitting where our biggest costs are, which is our low income population and our oldest population with multiple comorbidities. They use that technology much less. So let's talk a little bit about COVID. The US is a mess. I don't know what other way to say it. We don't have the same conviction, I guess, as a population to take care of each other. So when you guys are in lockdown, you're in lockdown. We are not in lockdown. Yesterday alone, we had 54,000 new cases across the US. We have over 165 deaths from COVID, and the numbers are rising. There are hot spots all across the nation. And what's happened in the healthcare system is because of that, people not being able to go to work, or a lot of what you'd consider service industries not open. For a very long time, retailers were not open. We're reopening all of that. We're seeing the consequences of reopening all of that. But it's driven to high unemployment because a lot of employees have been furloughed or actually have lost their jobs. What that does is it shifts the financial focus to typically state and local government. And state governments, the people enroll in Medicaid, they have no out-of-pocket costs in Medicaid, but that is something that rises state budgets and then state revenues, and because of unemployment and less tax revenue, they're out of balance. And so we have states, California is facing a $50 billion budget deficit. Of course, the hospitals have been facing high financial pressure because of cash flow issues and people not wanting to go into the hospital for what you consider elective care. Now that's starting to turn around, and hospitals are having a COVID wing and then a wing for their surgery units. But the federal government has been pushing hundreds of billions of dollars to the hospitals, just moving them as advance payments into our Medicare system to keep them afloat. So the situation's probably a lot worse than maybe sometimes you read about in Australia. And then, but what it has done is we had virtual care models, typically telehealth. So it's either just through the phone or actually through, you know, a FaceTime or a Zoom call. We had that in the commercial marketplace. It just started to get adopted in Medicare, and we had a federal mandate that said, look, we know we have to do more controls over telehealth, and there is potentially fraud in that, but we need to open it up to the entire nation. So we rapidly did that, and that helped us get people back into getting necessary services they need. And of course, other virtual care models with, you know, pharmaceuticals delivered to your home. It's rare that you have to actually go into a pharmacy. And then, as we talked about and Drew talked about, a rise in remote monitoring. And then, of course, we're all concerned about what's going to happen about those people who are just delaying care. So a truly Australian example is Australia has a very high incidence of skin cancer. So if you think you might have a melanoma, but you don't want to go into the doctor because you're afraid you might get sick, or might catch COVID, those types of things. We're worried about people like that. You know, a woman who's not gotten their mammogram, whatever that preventative test is, because the more they delay care, the more chances that something bad's going to happen. And of course, we want all the preventative measures done, childhood immunizations, et cetera. So we're really concerned about not only the short-term impact of that on the healthcare system, but the long-term impact of that on the health of people in the U.S. I'll talk a little bit about telehealth in the U.S. So in the U.S., it's tackling the full care continuum, meaning it's not just a GP visit, it's specialist visits, it's second opinions from specialists. I mean, it's behavioral health. Obviously, you can't do dental that way, but it's all of those, and health plans through the employers that they support, as well as the government, have expanded telehealth coverage. So it was rapidly rolled out in the U.S., and it continues to grow pretty dramatically. And you heard this morning already about Teladoc's acquisition of Livongo, one of the biggest acquisitions that's happened in health IT recently. So more and more of that remote monitoring and telehealth is happening and fueling growth. And now it's moved into mainstream consumers. In the past, you know, as an employee, I would get a card saying, hey, Teladoc, you can contact the doctor anytime you want and set up an appointment. I really didn't need to. After COVID hit, it made a lot more sense. So most of my doctor's appointments are via Zoom calls or through whatever tool they're tracking. But what it's helped with is minimizing the risk, obviously, of exposure to COVID through community spread. And you might say, is it really working with 54,000 new cases yesterday? Just think what it would be if we didn't have telehealth in the US. It's helped people with stay-at-home requirements, obviously. And then clinician shortages. In the US, if you are licensed, and this may be the same case in Australia, if you're a licensed doctor or nurse in California, you are not necessarily reciprocally approved in New York. And so when New York went through its worst spike in cases, we couldn't quickly transport additional doctors and nurses. And so the nation is coming up with solutions around that. But telehealth helps with that. Of course, it doesn't help with really actually treating the patient with COVID. And then, of course, there's patient monitoring tools, obviously, that can be used, breathalyzers and other things. But it does bring care to the masses. So, you know, some of the issues that have to be faced are rural and remote bandwidth for Wi-Fi. But in reality, telehealth does bring care to as many people as possible, and it can support that continuity of care, which is very important. And then, of course, reduces the patient travel burden. We have, while we don't have as big of a rural area in the US as Australia does, we do have rural areas where a person may have to travel 2 hours to get to a hospital. So we do think that there's going to be a lot of benefits, and it's here to stay in the US and will continue to grow rapidly. Of course, you know what's happening with telehealth in Australia. The Minister for Health said it was a key weapon in fighting COVID-19 pandemic. So now what's happening, of course, on March 30th, the government announced that all Australians would be eligible for Medicare subsidized telehealth. Now, not all services qualify. Again, it's much broader in the US. The health funds have started expanding telehealth services. And then there are consumer options where you can pay for telehealth services independent of Medicare. Right now, though, the infrastructure has not been built, and you do have data sharing restrictions. Some of the things Drew talked about, where people give rights to their data, happens much more frequently in the US, and we have a law called HIPAA to protect that data. So we're further along from that perspective, and there's a lot more infrastructure in Australia that has to be built to support telehealth. I'm probably going over my time, so I want to quickly just go over this page and remind people that whole person care is a driving force in the US, and I'd expect it is in Australia as well. And one of the factoids here is 70% of the millennials in the US have been diagnosed with a behavioral health condition. So we're talking about managing someone's behavioral health, their social determinants of health, and then their medical health, and making sure that's coordinated in a very transparent way to reduce total cost of care, but to improve outcomes. We do this through data and analytics. So this is the consumer health profile you see in the center of all the data that we have about a patient or a client's patient or insurance member. And we take data sources from whatever we can get, and as you heard Drew mention, we can bring all these data sources in, but that goes into our prescriptive analytics. And basically what it does is it drives clinical scoring, and it says, these are the people you really need to intervene with now, and here's the things you need to do. And so we've built that predictive model. It's become more accurate than the Johns Hopkins predictive model. And what we believe is health plans, government using this will make sure resources get to the right people, and that they do things in a proactive manner instead of reactive. I wanted to throw this in because digital health is it's such a opportunity in Australia, but you do have data restrictions that really keep you from looking at the whole person. Now, you do have medical devices and ultimately chips where patients communicate with providers. The medical device industry is strong. You have data aggregators, but today they're aggregating data in a de-identified way. And really what needs to be done is identified data needs to come together so you really get that whole person view. That's something that is, I think, part of the reason we were asked to be in the CRC was to show that aggregating that data about an individual really helps improve outcomes. And maybe eventually regulation in Australia will follow that. And then, of course, as we talked about, you need demographic and geographic data overlays so you can see the challenges with specific populations. So let me talk about what I think is going to happen in the US in the next 3 to 5 years, and I'm sure some of this in Australia. Virtual care is here to stay. It'll continue to expand. We will have remote patient monitoring. We'll have remote patient monitoring in hospitals. We now have a remote patient monitoring in aged care facilities with robots, where nurse practitioners can actually talk to the patient via an iPad that's on a robot. That'll continue to happen and grow, and there is a real demand for tools around that, and of course investment dollars in the US. Retail healthcare will emerge as a winner. In the US, CVS, which is CVS and Walgreens, two of the largest pharmacy chains, so similar to your Priceline, Chemist Warehouse, they are building primary care clinics within their retail pharmacy stores, so that people can go in and it's an easy place for them to not only take care of themselves through meeting with a GP or a nurse practitioner and getting their prescription at the same place. And they're expanding that to lab work and other things. So the retail pharmacy becomes a healthcare hub. And then this drive towards consumerism, and you heard that this morning, it's big in the US. We don't have price transparency the way we should. We have many more mobile payments than we did, but consumers are demanding more from their health plans and their providers, which is one of the reasons that we really got into population health, was to be able to have that engagement platform for consumers and our clients. And we think that there's no way that providers can be successful or integrated delivery networks if they don't understand the clinical risk of the patient. And that really shouldn't just be, did they get a lot of services? Because maybe they needed them. But it's those who will become a higher risk in 18 to 24 months. And what can you do to avoid that? And so that's the sweet spot that we as a company are going after.